we have a holiday coming up next week, St. Patrick's Day. It will be over by the time we meet again, so we're going to sing a little good luck for us here. Let's sing about the four-leaf clover. How long has it been since you sang this song? And nobody sang about the dead dog Grover. No, here we go. I'm looking over a four-leaf clover that I overlooked before. One leaf is sunshine, the other is rain. Third is the roses that grow in the lane. No need explaining, the one remaining is somebody I adore. I'm looking over a four-leaf clover that I overlooked before.
Now you may be seated. How about that? Our Sergeant of Arms today, and hold your applause to the end, is our very own Judy McHenry.
Well, you're about to experience me being Sergeant of Arms and only being informed 15 minutes ago that I'm Sergeant of Arms by Clayton Baker. So we all know how that feels, right? So today, my job as Sergeant of Arms is not keep you guys in order because we know that will never happen. So our Sergeant of Arms in our club says, get out $1 and put it in that blue bucket if you're a member. That money goes to our scholarship fund. If you're a visiting guest, don't put any money in there until you become a member. So today, this is a good caveat into what our scholarship fund supports. Today, we are honored to have one of our past Grove Rotarian Scholarship winners here. Macy, stand up for a minute. Macy, thank you. Macy Middleton Carper is the extraordinary wife of our own Rotarian, Gideon Carper, who is not here today because he and Charlie Wallace are at a basketball tournament. So, anyway, but Macy is the daughter of Rotarians, Christy Wallace and Charlie Wallace. And Macy attended Grove High School. She was a recipient of one of our scholarships, Grove Rotary Scholarships. She was also president of Interact. She was also a student of the month. Macy leaves Glorious Grove and goes to Oklahoma State and receives her degree. Go Pokes. From there, she moved to San Diego and went to University of San Diego and received her Juris Doctorate. Then she came back to Grove, and she is now a lawyer at Logan and Lowry in Veneta. Wow. So there it is, full circle, and she comes back. So I think that's just an extraordinary example of what our scholarship fund does. And she and Gideon are now members of the Grove community, willing to give back. So I think you can see how our dollars add up, and you get to see the benefits today. So that's it. Now I'm going to be Suzanne. I'm going to make an announcement. Next Wednesday is our Grove Rotary March Madness, and it's at the Drunken Rooster. It starts from 5 to 7. We will be supplying a free taco bar. It's a cash bar. Taco bar is free. Bring any guests that you want, your spouses, your neighbor, fifth removed cousin, we don't care. Come and have a great time. And also, I have a card here that is from, I'm not sure who it's from, but I'll tell you here in a minute. It's a thank you card. On behalf of everyone at the Home Hope, we want to extend a massive thank you to the Grove Rotary Club for your generous grant. This support directly impacts our basketball team, ensuring our athletes have the equipment they need to compete, grow, and have fun. We are so grateful to have a partner like you in the corner, Cassandra Fry, head of delegation. So this is a thank you card from a grant that the Home of Hope received from the Grove Rotary Club. So you guys are all responsible for that, and thank you.
And one more accolade about Macy. She's part of the program today. So literally, full circle. This is wonderful. Our Rotarian of the day is Ward Miller. Ward, is he here today?
No.
Okay, so he's not here. Rotarian of the day, are we finding him?
No, because he's recovering from surgery.
I'm sorry.
He's been in the hospital. We should not find him.
Forget what I said before.
Yeah.
Erase that. Rewind. Let's say special prayer for Ward. I did not know that he was recovering from surgery, so I apologize for making a poor joke. Our students of the month are Riley Dysert and Ramin Fatima. Our caterer, Kim with Timberden. What a wonderful job they've done. Let's give them a round of applause. Michelle Mann, if you will come forward, and Rod McFarland, please. I'll let Michelle explain what she's presenting to Rod.
Judy also talked me into doing other things. So,
Congratulations, Judy Mack.
If I stay down here, we're all in the same height.
okay. I know I'm short, but seriously. So, I'm Michelle Gann. I'm currently the president of the Bella Vista Club, and I've just sort of been told that I need to come to the Lobster Fest, so I'm going to gather some people and get tickets and come. But I am actually here today because I am the Paul Harris Society coordinator for the district. Some of you don't even know we have a Paul Harris Society. So I know that the Grove Club has their own foundation, but you all are also very strong supporters of the Rotary Foundation. You have a number of Paul Harris Fellowship people. You have multiple Paul Harris Fellowship people. You have major donors. You also have a couple of society members. What the society is, and it's a fairly new recognition. It was started sort of grassroots in 2007 and wasn't really recognized by Rotary International until 2013. It is district-led, so not every district has a Paul Harris Society. What that is recognition for Rotarians who commit to giving at least $1,000 a year to the Rotary Foundation. Some of them give more, some of them give right on the money. It just depends. But if you've made that commitment and are already giving at that level, then you should have received an invitation letter from me that says, why aren't you in the society? You're already doing this. So that's kind of where we're at today. Ron McFarland is giving at that level, and I sent him a letter, and he said, so why do I care about this? And I said, well, you're going to give at that level, obviously, whether you're a member of the society or not, but sometimes having that extra recognition means people come up to you and go, what's that thing hanging off your pin? What does that mean? And you get a chance to say, I really do support the foundation, and this is what I've committed to. So it's just a little extra recognition that we are allowed to grant people. So that being said, okay, you get this lovely certificate suitable for framing or sticking in a file drawer or whatever that says you are now a member of the Paul Harris Society. So you get that. You also get, this is called a chevron, and it hangs from your Paul Harris Fellowship pin. Whatever level of fellowship pin you have, it hangs from that and indicates that you are a society member. So I know you have a couple more society members in this club. If you don't have a chevron, get with me. I've got a drawer full of them, so I'll make sure that you get one. Now, thank you very much for your commitment to the society and to the foundation. We appreciate it. Now, I said Judy also kind of grabbed me and said, okay, since you're going to be up there, you get to do other stuff too. So, Terry Airy Did I say that right? Terry, come up here. You are being awarded your Paul Harris Fellow +4 pin today. So this means your Paul Harris Fellow pin now has 4 little blue stones on it. When you get to 5, they turn red. So I'll just point it out. But this is thanking you for your continued support of the Rotary Foundation. Thank you.
Congratulations, Terry.
Now, Susan Bass. Bass? Okay. Okay.
Susan Bass, come on down.
I love getting to give these things out. Susan is getting her Paul Harris Fellow +7. So, that's pretty damn good. So, you get the red stones. So, Terry's going to have to move up to red now, all right? So, you get the red stones, and again, we appreciate your obviously consistent support of the Rotary Foundation. Thank you. All right, now I'm going to be glad to
Thank you. Congratulations, Susan and Terry, very much for your support. Rotarian announcements. Pauline Hill with Lindenwood, she wants to make an announcement, and we do have a board meeting today at 1 o'clock. Just a reminder, actually, about Lindenwood. One reminder, the workday, March 28th, is coming right up. And we have a list of several, well, we always have a list, but this has a lot of tasks on it. And Jim Reynolds is developing the list, and he'll be talking about that next week. But there's jobs for everyone, even little kiddos. So, and by the way, after the last week, there will be lots of sticks to pick up. So, the other thing I know that a lot of you come to our fundraiser, the garden party. We had originally planned to have that on May 2nd and decided it's just too early. So the date for that has been changed to June 20th. It may be warm, but fewer chances of rain, we're hoping. So hope to see you there. And at the back, Diane Hampton has a sign-up sheet for Lobster Fest committee, so please see her before you leave today. Get on the committee if you're not on one, or see if you're a chair or co-chair. And now, Macy, would you come, please?
Hi, thank you guys so much for having me today. Obviously, with my long history in Grove Rotary, when I come here, it feels a little bit like a family reunion. I get to see literally all of you guys. So many of you have been my mentors, my support system, my #1 fans. So I just wanted to quickly say thank you so much for all of the love that you give to me. But the reason that I'm here is kind of funny. If you may have heard, I started working at Logan and Lowry and Bonita a little over half a year ago. And throughout my time working there, I joined the group of lawyers that serves the Community Health Center of Northeastern Oklahoma. And I didn't know anything about it. I was just told to show up to a meeting. And I started to learn more about their mission and what they do, which is to serve vulnerable communities and provide healthcare to people that can't afford it. And I just thought, wait, this is kind of the coolest thing ever. How did I not hear about this? And I said, you know, Mom, did you know about this? She goes, I never heard about it. And I was sitting in a board meeting, and all of a sudden I found myself speaking when I probably should have been speaking, and I said, oh my gosh, you have to go to Grove Rotary right now. I go, oh, okay, we'll go to Grove Rotary then. So I drug the wonderful Janet Mendez here to speak to you guys, but I think that her insight is so incredible because her story with the Community Health Center actually starts with her walking through the front door as a patient. Now she is a healthcare provider for the clinic and the CEO. So if you go to the clinic for care, you literally might receive care from the CEO, which I think completely speaks to her heart for service. She has been a registered nurse in the state of Oklahoma for the past 14 years and CEO of the Community Health Center of Northeastern Oklahoma for 5. I also want to take time to recognize two of the Community Health Center of Northeastern Oklahoma board members, former Senator Rick Littlefield and former Representative Ben Loring. Thank you so much, guys, for being here. They are awesome gentlemen to work with, as you all know. So without further ado, I would like to introduce the incredible Janet Mendez.
Hi everyone, again, I'm Janet Mendez, and it's my pleasure to be here today to speak with you guys about community health centers. I'm with Community Health Center of Northeast Oklahoma. You will hear me refer to that as CHC-NEO. During the presentation, it's just much easier to say. We're also going to test my hand-eye coordination today, so here we go. Community health centers, for whatever reason, seem to be the unintentionally best-kept secret around. Really, what is a community health center? Where do we start? Community health centers are also known as federally qualified health centers. What that means is we receive federal funding to provide health care to low-income and uninsured patients. We provide those services based on a sliding scale, based on household size and income. So that amount that an uninsured or low-income person is going to pay can move on that slide. We're not a free clinic, but we also won't refuse service due to someone's inability to pay. So cost is never a barrier to care with a community health center. We are governed by a board of directors drawn from the communities that we serve. So the people that are steering our ship know the waters. That's kind of how I like to say that. They know what's going on in their communities. They know what's needed in their communities. Those directors, also 51% of them are also patients of our health center. So they're receiving their care from the place that they govern. So that's kind of unusual. The board of directors are also responsible for determining our nominal fee. And what that nominal fee is the least amount a patient will pay if they're utilizing our sliding scale. So our directors have determined for our health centers that nominal fee is $10. So basically, that's a doctor's visit for $10. We don't ever want cost to prevent somebody from receiving care. Community health centers have actually been around since 1965. We were originally known as neighborhood health clinics, and I really think that is the best description you're ever going to hear. I don't know why they changed it, but they did. So nationwide, there's over 1,500 health centers served with 17,000 locations. So community health centers are big. In 2024, community health centers took care of 52 million patients, or 1 in 7 Americans. 1 in 3 of those people were from rural areas, so community health centers do serve our rural areas. That's nationwide. What does that look like for us here in Oklahoma? In Oklahoma, we have 21 health centers with almost 200 sites. To say that we serve the low income is kind of an understatement. 62% of the patients that we took care of as health centers are less than 100% of the federal poverty level. Not at 100%, not 150%, they are less than 100% of the federal poverty level. That is saying something that we are producing for the federal funds that we receive. I was surprised to see that number, and I do this. Also, of those almost 200 service sites here in the state, 76% of them are in rural areas, so our rural folks are getting care through community health centers. Us personally, how we got started as the local community health center group, back in 2009, a group of community leaders saw a need in our counties for low cost health care, and they were trying to find a way to deliver that for the people. How do we get this service to them and make it affordable? They researched and applied for the very first grant to establish a community health center in our areas. That was a long process. The first grant did get denied. There were several applications and revisions that took place. They had to establish an actual organization to administer that grant. That's where CHC-NEO comes from. That whole process was about 5 years, so we have some community leaders that put in a lot of effort to make this happen for our communities. And that, again, took about 5 years, and we opened our doors in March of 2014 in Afton. That was our original first community health center in our area. Since that time, we've expanded to 5 other communities in the 3 county areas. So we have Welch, Commerce, Veneta. Most recently, we added a site in Jay. So that's 5 service areas in the 3 county area. So what's our mission, really? What do we set out to do as community health centers? We want to, first and foremost, increase access to that affordable care. We want people to get health care. We just don't want cost to be a barrier. We want to get the preventative services out there. We want to catch things early. If we can catch them early, people have better outcomes. If you're not getting routine health care, things can get away from you. So we want to catch stuff early. You're going to hear me say a lot about chronic health conditions. And what I mean by that are things like high blood pressure, diabetes, COPD, things that are super prevalent in the general population, in our areas, especially in the patients that we see. So when you hear me talk about these chronic health conditions, that's what I'm talking about, and generally great outcomes if people are receiving routine care for these things. The other thing that community health centers try to do, we want to reduce ER visits if we can. We want to take the burden off of those folks. Those guys do a great job in emergencies, but for those chronic conditions, if people feel like they don't have any other choice, they're going to utilize the ER. The other thing that we do is we try to address what we call the social determinants of health, and if you're not familiar with that term, basically what that is things that maybe aren't medical, but they do affect a person's overall health and wellness. So that's in a nutshell what we set out to do in our communities. So how do we do that? So we locate our health centers to try to make them easily accessible for people. Our Veneta and Commerce Clinic, we actually have patients that walk to their appointments. We're that close to home for them. We never want transportation, how do I get here? I don't have gas. We never want that to be a barrier to people getting care, so we try to put the health centers where we think there's the greatest need. That sliding fee scale that we use, huge. Probably one of the biggest things that we do. Affordable, affordable, affordable. Again, we're not free, but we're also not going to refuse care if someone can't pay. We're going to take care of you. Early detection and screenings, colon cancer, breast cancer, prostate cancer, all those things that we all need to screen for. We do help people with that. And then those chronic conditions, again, if you can get routine, continuous, consistent care, your outcome is going to be so much better. We want to provide that to people. And then again, those social determinants of health, we're going to help connect people with resources for food if they're experiencing food insecurity, clothing, somebody needs a winter coat, and just other needs, utility assistance, just different things to try and help, again, the whole person and remove any barriers to overall health and wellness, not just those medical things. So the primary care. And this is a really big umbrella. I've just put a few things up here describing some of the services that you can receive at a community health center, and that's child checks, those well-known exams, those screenings for cervical cancer, ladies, get those done. Again, the chronic disease management, that diabetes, hypertension, COPD, and sick visits. I woke up with a sore throat. Maybe I have the flu. Maybe I pulled a muscle mowing my yard this weekend. All those things fall under comprehensive primary care, and those are things that we can treat you for at one of our community health centers. So that's the medical piece. That second piece, those social determinants of health. Some of you may know Christy Van Horn. She's pretty active in the communities, but she's our outreach and enrollment specialist. And what Christy does, she's great at connecting needs with resources. So those people that maybe need to get connected with a food bank or a clothing closet. Maybe they can't pay their electric bill this month. Christy is amazing, again, at making those connections. Christy's also a certified navigator, and what that means is she can help people with insurance enrollment, like the marketplace or the healthcare.gov. Sometimes that can be overwhelming. She's there to assist with that. Kind of the same thing with Medicare and Senior Care. She can help people get enrolled, reestablish enrollment if, for some reason they missed some documentation. And just because Christy helps with insurance, that's not, I'll help you, but you have to come to our health clinics. No. All of these services that are listed up here that Christy provides, they're available to anybody in the community. You don't have to be at one of our health center patients if it's open enrollment in the fall for Medicare and you're like, I don't know, can't get logged in. Call Christy. She's available to anyone in the community. Again, you do not have to be a patient at one of our health centers to access Christy or the resources that she can connect you with. So we're going to put all that together. I'm going to do my best at putting this all together for you. And I like to use our pretend patient Tom. And Tom can be your neighbor, someone you go to church with, maybe even somebody that you work with. But Tom, he works full-time, but maybe it's not a great paying job. It's paying the bills, but there's not really any extra. And his employer doesn't offer insurance. He's got high blood pressure. He's had high blood pressure for years. He knows it. And when it gets real bad and he doesn't feel good, or maybe he's been out of medicine for a couple months because he can't afford to go to the doctor, he's going to go to the emergency room. And he knows that the emergency room is going to take care of him regardless, if he can pay or not. So he's going to go there and he's going to get treated. Maybe his blood pressure's real high right now. They're going to take care of him, and maybe they're going to give him a month's worth of medication. Emergency room is never going to say and follow up with us in 2 weeks. They take care of what's going on right now. That's what they're here to do, that's what they're meant to do, and they're awesome at it. But that's not a great way to manage blood pressure or diabetes. That uncontrolled blood pressure is going to lead possibly to more problems down the road. We think about dialysis only applies to people with diabetes. Number 2 reason that people get dialysis is uncontrolled blood pressure. So obviously we want to get these things that we can control under control. Also, Tom, he's working and he's paying the bills, but sometimes, the food runs out before the next paycheck comes in. And that's kind of the cycle. It's crisis care is kind of what we refer to it. I'm okay until I'm not okay, and I can't afford to go to the doctor, so I'm going to go to the ER, and I get it handled there for a little bit. And it's crisis care. It's not consistent care, and it doesn't provide the best long-term outcome for people. What we hope happens is someone tells Tom about community health centers. If he knew about them, he's going to have that care closer to home. It's going to be affordable. He most likely is going to qualify for that $10 nominal fee. He can come to the doctor often as he needs to for $10. We're going to make sure that the medicine that he's on is working, that he has the medicine consistently, and we're going to make sure, run some lab tests, make sure we don't have some high cholesterol or whatever, any other potential problems out there. We want to look at everything. While he's there, we find out, you need some help with food. We're going to direct him to Christy, and she's going to get him hooked up with a food bank. And maybe while he's there, she's able to help him navigate that healthcare.gov website and find out, I can't afford insurance. I didn't know this was out here. So we go from this, again, I guess basically crisis care. I know I need to go to the doctor, but I have other things, and I feel all right now until I don't feel all right. And you just keep this, constant cycle going, whereas come to a community health center, we address the whole person. We're going to help you with food if we can. We're going to make sure that you have medication. If you can't pay for your visit this month, that's okay too. And we're going to ask you to follow up in 3 months. We're going to want to keep an eye on you. We want to make sure it's the right medicine. Something else didn't pop up since the last thing we saw you. That consistent care, if you can catch things early, just such a much better outcome for patients. And if cost isn't a factor, then why wouldn't you? we want to stay on top of our health as best we can. So I talk a lot about community health centers receiving federal funding to treat low-income and uninsured patients. You may be asking yourself, can I use a community health center if I have insurance? That is a resounding yes. Because our federal funding is a finite number, any revenue that we can generate through insurance payments helps us to provide more care to the uninsured. So the more insured folks we see, the more uninsured folks we see. So by choosing a community health center for care, for our insured patients, they're actually you're helping your community by doing that. And again, we talk about that sliding scale for low income and uninsured. There are people out there that, yes, they have insurance, but that insurance is catastrophic care. So every year my deductible or out of pocket is $7,500. We literally have a patient with a policy like that. He's never ever going to make that deductible. He's always going to be paying full price for a visit, and again, that becomes a barrier. That sliding scale, again, based on household size and income, we got this particular patient that I'm talking about on the sliding scale qualified for a 40% discount right out the gate. So that sliding scale isn't just for uninsured. It can help people with insurance as well, especially those catastrophic plans where you just have these crazy deductibles that no one's ever going to meet unless they end up in a hospital. So I throw that out there just for general information. So I know I'm throwing a lot at you today, and there's a lot to community health centers. That's really just kind of the tip of the iceberg. But really what I hope everyone takes away today from this is there's community health centers right here in our communities. We're here to take care of those uninsured and low income people. Please spread the word. Know that we're there. Please, we want to take care of our neighbors. We've got that sliding scale, and cost should never be a barrier to care, ever. We do that comprehensive primary care, so all those things we talked about earlier. We take insurance, we love insurance. We do have transportation available. Sometimes patients don't have a working vehicle, or maybe they don't have a vehicle at all. We can get them to their appointments, so we can help with that. We want them to get that care, whatever it takes, basically. And then we're great at connecting needs with resources. So those big things in clothing closets, utility assistance, whatever that may be. That's really, again, what I hope stays with you from a little discussion today. And that's kind of all I had. Again, we are governed by a board of directors from our local community, so we're locally governed. And currently, these are the directors serving on our board. And that's all I have.
Does anyone have any questions? Okay.
Couple questions. How do you provide lab, x-ray, the ancillary services for the people who are on the $10 list? And then the second question would be, are your providers all RNs, or do you have physicians or nurse practitioners, PAs? What providers do you have?
I have the answer to that. So we, because we're a community health center, so I say that community health centers and federally qualified health centers, that's all. It's not just our name, it's a designation. And as an FQHC, we partner with a lab that can provide services either at a reduced cost, or for those that simply can't pay it, the clinic will pay for those lab services. We'll get them done. Same thing with basic x-rays. We have agreements with the local hospitals. We will send a patient to them if they don't have insurance. The hospital will bill us whatever current Oklahoma Medicare rates are, and we will reimburse the facility. Our providers, our Chief Medical Officer is Dr. Richard Tidwell, MJ, and our other clinics other than the J Clinic are staffed either with nurse practitioners, so advanced practice nurses, or physician assistants. Currently, we're all nurse practitioners, but we have had physician assistants in the past.
How are medications covered, if at all, prescription meds,
Is that included in the visit or not?
It is not included in the visit. A lot of times, we try to prescribe off of the Walmart $4 list, for lack of a better term for that. We do also participate in the 340B drug program, and some of you may or may not be familiar with that. It gets kind of messy to try to explain, which is why I didn't actually mention it here, but I'm glad you brought it up. We do have access to a lot of medicines, not all of them, at a reduced cost. The fee for those, again, is $10. That's just a coincidence to the patient. That's a 30-day supply of these meds that we can get through this 340B program. And again, if a patient can't pay that $10, we're not going to withhold the medicine, we're going to get it to them. But yes, we do participate in the 340B drug program, if anyone's at all familiar with that.
Do you provide any prenatal care?
We like to refer our prenatal patients out for OB services. And further on that, actually, pregnant women basically immediately qualify for Medicaid coverage, so we're able to get them insured and we can get them to the specialty care that way.
Very informative presentation, thank you. 2 questions. With Delaware County and other counties around here being so below poverty line or low income, how are you reaching those individuals with your message? And then second of all, what's the average wait time throughout the facilities?
The primary way that we get the word out about our services is through presentations like this. Christy, I mentioned earlier, is very involved in the 3 counties. The Delaware County Coalition is one of the big ones that she participates in. We attend health fairs, flyers. I say we're like the best kept secret unintentionally. We try, like I said, mostly it's through community groups that we try to get the word out. And I'm sorry, I didn't, oh, the average wait time? It depends on the clinic. Most of them same week. Jay's a little different. Jay came to us as an established clinic, so their schedule's pretty full. Most of them within the week. Sometimes, a lot of times it's same day, depending on what's going on. But no, it's not a 3-week or a month wait. If you have to wait more than a week with us, something's up. So we can get you in pretty quick.
What is the J clinic you were talking about that you took over an established clinic?
Yeah, so back in 2020, Dr. Tidwell approached us about joining our organization as a federally qualified health center. He's been in, well, he started in J in private practice over 15 years ago. He's been with some other groups, rural health care organizations, but never a federally qualified health center. And he approached us about joining our organization, and we were able to acquire that practice. But again, he's been there at least 15 years, so his panel is very full, which is not to say that no one can get in there, but just know that that's going to be a little longer wait.
Rod took my first 2 questions. Still might be more. What's the average rate or fee that your patients pay? And $10 the lowest, what would you say is the average for most people?
$10 front.
Oh, really? Okay.
Yes. And again, 62% of Oklahoma healthcare patients below 100% of the federal poverty level. The majority of those patients on the slide are at that nominal fee or that $10 fee.
What about your funding? Is there a fear of you losing?
There's always a fear of losing funding. So grant periods, up until this year, a grant period was a 3-year period. So you were guaranteed funding, guaranteed funding for that 3-year period. They just changed that to 4. So once we get that grant approval, barring some major shutdown, country goes bankrupt, that funding is guaranteed from year to year for us.
Janet, would you speak about the quality of the medical care and the recognition that we've had?
Yes. I'm trying to do that. There's so many moving parts to this. So the way that we're held accountable for the federal funding that we receive, this is how I equate it. So if you're in school and you're receiving scholarship, or not scholarship funding, but financial aid, you have to be passing your classes to continue to get that aid. For health centers, we submit a report every year, and they grade us on about 15 different clinical measures. How many of our patients are getting mammograms? How many of our patients have diabetes that is well controlled? How many of our patients have blood pressure that's well controlled? Like, there's about 15 of them. And we are graded nationally. We don't get bell curve because we're in Oklahoma, and somebody gets a different curve because they're in New York. And we received 2 years running Silver Star from our funding agency, so from the federal government, for the excellent quality of care that we provide our patients. Again, I'm biased. I think we do a great job. We've received 2 of those in the last 3 years, I believe. Our data goes in February, so when I give you those numbers for patients, our 2025 numbers, we submit that in February, and that information will be available in August, and hopefully we'll have another gold or silver star for our quality of care. But again, I'm biased. I think we do an outstanding job. That we have been federally awarded for our quality of care twice.
I'm always amazed at, over here, I just joined our healthcare system and Dr. Beckel, Dr. Tidwell's been a long time partner. You know, I've said that if we took all the federal and state money that's just poured into our county and the adjoining counties, we have 3 Indian clinics, we have 2 VAs, we have you and Danita, we have a whole private sector, we have a health department, we have a Christian medical clinic. I've always thought if we had all that money and we just used it efficiently, we would have the Taj Mahal of the health system in our county. And now we've learned that this administration has committed $50 billion in America to rural health, designated to rural health. And I don't hear much about it. I know that many of the physicians here in Grove don't qualify to receive federal aid because we are not a designated, need. It's kind of crazy. Every county that we touch that doesn't have a hospital, that doesn't have a doctor's office, doesn't have a rural clinic, we see those patients. I take care of many of those patients. So I was just wondering, have you heard anything about when this money is going to be available and how is it going to affect your clinic? And is there a way to bring us together?
I wish there was an easy answer to that. Unfortunately, there isn't. As you know, and healthcare is complicated. It gets 3 times more complicated when you bring in federal funding agencies. I know that there has been an increase in community health center funding. I don't know how that's going to be dispersed or how it's going to affect us. We're all just kind of waiting to see. We've had a lot of ups and downs recently with what we should anticipate funding to be, or maybe cuts, or maybe increases. We're just kind of in a holding pattern right now. I know that's not a great answer, but that's kind of where we're at.
You haven't heard anything about the money, the federal money. Is that going to increase your budget, or is it?
No. For us, no, it won't. It may in other health centers. I know that there's a community health center out of Tahlequah, and they received some designated funding to open a new clinic near Tahlequah. Don't get me to line, but that's the only specific thing that I've heard. We are not anticipating for our health centers an increase. If we get one, that would be amazing, but I'm not going to count our chickens before they hatch.
Very elementary question, but if I know somebody that needs this service, is it as easy for them just to call one of the clinics in your community health center organization and just make an appointment? That's it.
Yes, the answer to that question is that's it. Call, hey, I need an appointment. I have fill in the blank going on. Put you on the schedule. Like I said, it's rarely, if ever, more than a week wait. Sometimes same day, next day. So yeah, just call. Super easy.
Do you have a 24/7 number that people can call that will direct them to any clinic?
So yes, well, yes and no. So yes, we have a nurse advice line that comes on after hours for us, and they will triage those patients, direct them to, if they need to go to the emergency room, they're going to direct them there. If it's something they just want to call and say, hey, I need my medicines refilled, we'll get that message the next day and get that taken care of. And our clinics themselves, no, we do use that after hours service line.
With the changes in federal funding for healthcare, Medicaid primarily, have you seen your visits, utilization explode?
We have not yet. We are bracing for that.
Any other questions for Janet? Let's give her a round of applause, guys. Thank you again, Rick Littlefield, Ben Loring, Macy, and Janet for being here today and giving that wonderful presentation for us. Final announcements. Next week we will have the FBI agent here for our program, so that should be very informative as well. Put up the blue chairs, put out 7 middle, please, and if you will stand with the 4-way vest. Of the things that we think, say, or do, is it the truth?